Welcome back to the session on part 2 of February 2010 question paper. The first question we are going to see here is adamantinoma. This is not much frequently asked question. This is just like a bouncer. You can go through the few points I have mentioned: bone tumor, 30 to 40 years, malignant potential, most common site being the tibia. Few points you can go through and you can manage. Just for completion's sake, I have included this. Now, coming to the complications of blood transfusion. Before going to complications of blood transfusion per se, I would like to talk about few other things of blood transfusion. I mean the introduction and various components of the blood. After that we will go for complications of blood transfusion. Okay. Now, coming to blood and blood products. First thing I want to talk about is a donor. Donor is the one who is donating the blood. So how much ml of blood a person can donate? How much? 100 ml, 500 ml, 1000 ml. So how much is there a specific volume up to maximum a person can donate? Yes, a person can maximum donate up to 450 ml only. Okay. Now, can I donate every month? Can I donate once in every 2 months? No, there is also criteria for that also. The maximum you can donate is 3 times in a year. The maximum you can donate is 3 times in a year. Now, you have to screen the donor blood. What are all the diseases you are going to screen for? You have to screen for HIV, HBV, HCV, and syphilis, and some other also, like depends on the cases. You have to look for malaria or something, depends on the location. Now, donations are going to be leukodepleted. Before donation, you have to check the ABO as well as the RH status of the person who is donating the blood. After that, you have to process the blood into what? Into various blood products. Now, we will look into blood products one by one here. Whole blood. So, you already know there is PRBC. PRBC means what? It is packed RBC. Now, there is whole blood and there is packed RBC. What is the advantage of whole blood over packed RBC? Is whole blood contains what? It is going to contain coagulation factors. Okay. Whole blood is coagulation factor rich. That is the advantage of whole blood over PRBC. Now, PRBC means what? It is a concentrated pack of RBC, and the volume of PRBC is how much? That is 330 ml. Now, if I take a PRBC, one packet, if I take 1 unit, can I use this after 1 year? Can I use this after 6 months? Now, what is the shelf life of a PRBC unit? If I take the sample from the patient today, within how much duration I have to use that unit of PRBC means it depends on what is the composition we are going to add to that. If it is made of acid citrate dextrose, then the shelf life of PRBC is 28 days. If it is made of citrate phosphate dextrose agar, then the shelf life is 35 days. If it is CPDA plus saline adenine glucose mannitol, if it is made of saline adenine glucose mannitol, then the shelf life is 42 days. Okay. Now, what is the temperature at which fresh frozen plasma is stored? The temperature storage is -20 for fresh frozen plasma, whereas for cryoprecipitate it is -30. Now, coming to fresh frozen plasma, what is fresh frozen plasma is going to contain? It is going to contain coagulation factors, very important. Now, another student is going to ask me, sir, cryoprecipitate also contains coagulation factors. Yes, you are correct. But what coagulation factors they are rich in? They are rich in factor 8. It is also rich in fibrinogen. So that is the reason why if there is factor 8 deficiency, such as like in hemophilia A, I have to use cryoprecipitate. If it is a low fibrinogen state, then also I can use cryoprecipitate. Coming to platelets, what is the temperature at which platelets are stored? They are stored at almost room temperature, that is 22 to 24 degrees. Now, where we are going to use these platelets, you already know we are going to use them in thrombocytopenia, or if there is any platelet dysfunctions, we have to use platelets. And this might be something new point to you. Prothrombin complex concentrate, very important topic. So what is prothrombin complex concentrate is rich in? It is rich in 4 factors. Can you guess the 4 coagulation factors? These are the ones which are made by the liver also. 2, 7, 9 and 10. 2, 7, 9 and 10 are the 4 factors where PCC is rich. Okay. You can also call it as 4 factor complex also you can call. Now what is the situation? What is the condition where we have to use this prothrombin complex concentrate, if you ask me? Suppose there is a patient whom I have given a anticoagulant. Let us take example of warfarin. If I have given warfarin to one patient, due to warfarin, now the patient presents with bleed. Now to stop that bleed, I have to reverse the action of this warfarin. For that, I have to use what? I have to use this PCC. Okay, 4 factor complex or prothrombin complex concentrate I have to use. Now you have seen many a times many patients going through blood transfusion. But what are all the situations where blood transfusion is indicated? What are all the indications of blood transfusion per se? If there is an acute blood loss, that everybody knows, you have to give a blood transfusion. If there is perioperative anemia, either before a surgery or after a surgical procedure, if the patient has anemia, then you have to transfuse blood. That also you already know. Symptomatic chronic anemia, also you have to transfuse the blood. Now, suppose there is a patient who is undergoing surgery. Can I transfuse blood to each and every patient? No, there is some specific criteria to tell whether the transfusion is indicated or not. If the hemoglobin is less than 6, this patient may probably benefit. This patient may probably benefit from blood transfusion. If the patient has any value which is between 6 to 8, transfusion is unlikely to benefit. Okay, transfusion is unlikely to benefit if the patient has a hemoglobin value between 6 to 8 in the absence of bleed. If there is bleed, then transfusion is definitely useful. But in the absence of bleed, if you ask me, is it useful, means it is unlikely to benefit. The moment patient has a more than 8, then there is no indication for transfusion, provided in the absence of any other risk factor. If the hemoglobin is more than 8, then no blood transfusion is indicated, provided there are no other risk factors of bleed. Now, coming to ABO system. Okay, this is for this. Okay, now coming to ABO system, let us take example of a positive blood group. If the patient is A positive, then he is going to have antibodies of B within his serum. If the patient is B positive, then he is going to have antibodies of what type? He is going to have antibodies of what? A. Similarly, if the patient is AB positive, he has A, he has B, then what are the antibodies? He won't be having any antibodies. If at all the patient is O positive or O negative, then he is going to have antibodies of both A as well as B also. Now, which blood group is universal donor? Is it O or is it AB? Yes, it is O. Why I am calling this O blood group as universal donor? Why I am calling this A blood group as universal donor? Because no antigens to provoke a reaction. So there are no antigens to provoke a reaction, that is O blood group is a universal donor. Now coming to AB blood group. AB blood group is what? It is universal recipient. Why it is universal recipient? Because there are no circulating antibodies. Because there are no circulating antibodies, that is why AB blood group is universal recipient. Now coming to rhesus. If you ask me rhesus, that is Rh positive or Rh negative status. Now the question is, how much of the population is Rh positive and how much population are Rh negative? If you ask me, even 85% of the population are Rh positive. Only 15% of them are Rh negative. If I take AB blood group, suppose I take A positive. Now, is the patient is going to have antibodies of B? The answer is yes. If I take B blood group, then he is going to have antibodies of A. But unlike ABO blood group, Rh blood group antibodies are not present. Okay, even 15% of the cases are Rh negative. Now the question is, do these 15% are going to have antibodies against Rh? The answer is no. Antibodies to D antigen are not naturally present in the serum of the remaining 15%. So what are the conditions where you can see even Rh antibodies within the body of the person? Please note them down. If I have transfused them with Rh positive blood group, if I have given him for a Rh negative person, if I have given blood transfusion of a Rh positive blood, then he is going to have antibodies to the Rh. Now, what is the other condition? It may be acquired during delivery of Rh positive baby. This also may occur. If the mother is Rh negative and the baby is Rh positive, sometimes there may be development of antibodies against this Rh in the mother. Okay, these are the two conditions I want you to remember. Now, everyone might be aware of the word cross matching during a blood transfusion. Now, why we have to do cross matching? To prevent the transfusion reactions. That is straightforward answer. So full cross matching means everything I have to look at. It may take up to 45 minutes to get a full cross matching done. Suppose if it is an urgent situation where I require blood, then I need not do complete full cross matching. Then I can do ABO or RH match. If the ABO, suppose the patient blood group is B positive and I have checked the donor blood group and I have checked it is B positive, then I can immediately give the B positive to the patient. Okay, in urgent situation, only by matching ABO and RH I can give this. It will take only 10 to 15 minutes of the time. If it is an emergency condition where I do not even have time to take a B positive blood group or a specific blood group is not available and it is an emergency situation, what I have to do? I have to give group O blood group to the patient. For females, I have to give O negative. For males, I have to give O positive. Okay. Whenever you are doing a blood transfusion, always check the patient details and always check the label details. Check the patient details. Yes, it is mentioned AB positive. Check the label from the donor packet. It is also showing you AB positive. Then only you have to transfuse. It has to be, both has to be matched. Otherwise, what will happen? ABO mismatch blood transfusion will occur and the patient is gonna land up in complications. Okay. Now we are coming to our original question, that is complications of blood transfusions. This is our actual question. So far what we have discussed is just the basic. Okay. Now complications of blood transfusion is a very important topic. Almost once in a year or once in 2 years they will always ask a question on the complications of blood transfusion. They may ask you an essay, they may ask you a 4 mark, or can ask you a 2 marks, or whatever. Questions are frequently asked on this topic, that is complications of blood transfusion. Not only for undergraduate level, even when you look at the postgraduate entrance levels also, many questions they have asked related to complications of blood transfusion. So with attention we are going to look at it. So first complication I want to tell is febrile non-hemolytic reaction. So many of you might be having a doubt, sir, why are you starting with the febrile non-hemolytic reaction? Because it is the most common complication of a blood transfusion. It is what? Febrile non-hemolytic reaction. Okay. Now, sir, you are using the word febrile. Yes, I am using the word febrile. Means the patient is going to have fever. So in many complications, you can see fever, you can see chills. Okay, fever and chills are common to most of the complications of blood transfusion. You can write wherever you want. Okay, and mild dyspnea might be there. Okay, now within what time I am going to see this reaction? Now I have done a transfusion to the patient. Within what time the patient is going to develop this complication? Within 6 hours. Within 6 hours I am going to see this complication. Now due to which blood product transfusion this reaction is more common? Maybe due to RBC, maybe due to platelets. Okay, RBC or platelets. Somewhat uncommon with FFP or cryo. It is uncommon, but it is seen with RBC or platelets. Due to some inflammatory mediators. This is occurring due to some inflammatory mediators. Now the question is, where are these mediators coming from? Inflammatory mediators which are derived from, yes, this is the question, donor leukocytes. So which is responsible? Donor leukocytes are the one which are responsible. Not completely directly donor leukocytes, they are the inflammatory mediators which are going to be derived from donor leukocytes. Now, the frequency of these reactions, febrile non-hemolytic reactions, are gonna increase with storage. Okay, suppose if I store blood for much more longer time, then the risk of this complication is much more. Okay, how to treat this case? How to treat this? Is febrile non-hemolytic. It is just a febrile, presenting with fever, presenting with chills, sometimes maybe mild dyspnea. How to treat febrile? Okay, I have to give antipyretics. That's all. Treatment also you have to write for each and every complication. Okay. Now, coming to allergic reactions. First complication I have mentioned is febrile non-hemolytic reaction, which is due to inflammatory mediators which are derived from donor leukocytes. What is the time period within which we are going to see? Within 6 hours, very important time period. Okay, with the frequency of complication of this the frequency of this complication is much more when you are going to store blood for a longer duration. That's all. Now coming to allergic reactions. In which patient the risk of the allergic reaction is going to be high? If the patient has IgA deficiency patient, then definitely there is a risk of allergic reaction. Now, what it is triggered by? This reaction, allergic reaction, is triggered by IgG antibodies, not IgA. The patient is IgA deficient, but allergic reaction is occurring. Allergic reaction is occurring due to IgG antibodies that are going to recognize IgA in the infused blood. So in a simple way, I will try to explain this. Suppose there is our patient. Our patient is already IgA deficient. What he has is IgG. Now I have transfused a blood. In that blood, obviously there is IgA. Okay. Now IgG antibodies which are present in my body are going to react with IgA which is present in the infused blood. This is why allergic reaction is occurring. Okay. Now common sense tells me the treatment of this allergic reaction has to be what? I have to give antihistamines. For allergy, you should always remember antihistamines are most useful. Okay, that is why antihistamines are the treatment for allergic reactions. Now coming to the next complication is hemolytic reactions. Hemolytic reactions. Okay, now first thing I am going to mention is acute hemolytic reactions. Acute hemolytic reaction. So why this is very acute? Why this is occurring such acutely? Because it is due to preformed antibodies. Preformed antibodies against what? Donor red cells. Preformed antibodies against donor red cells. Okay, that is why due to the preformed antibodies, suppose we take, this is our patient has what? Preformed antibodies. Now I have what done? I have transfused the blood. This blood has what? Donor red RBC. Our blood has what? Preformed antibodies. These preformed antibodies are going to attack what? Donor red blood cells. That is why there is hemolysis, very important. Okay. So what is the risk? I mean, if you have done a ABO incompatible transfusion, then there is a risk of this hemolytic reaction. Okay. Now, what are the clinical features with which the patient is going to present? I have already told you fever and chills are present in most of the complications. I am writing the same routine things. Along with that, there is flank pain also. But what is more important? These are present, but what is more important? They are going to appear rapidly. Fever and chills are even present in febrile non-hemolytic reaction also. But what is the difference with acute hemolytic reaction? These are appearing what? Rapid symptoms. Acute hemolytic reaction. Okay. Now, if at all I have to do a test to confirm this, I have to get a direct Coombs test done. direct Coombs test is done and the test is going to be positive. Direct Coombs test is positive in acute hemolytic reaction. Now, signs and symptoms which are occurring are due to what? They are due to complement fixation. I have told you this is hemolytic reaction, means there is obviously a chance of hemoglobin urea. In some cases, in some severe cases, I can even see what? Disseminated intravascular coagulation may occur, or the patient may go into shock, or the patient may get acute renal failure, or even the patient can die also. Okay, this is what about acute hemolytic reaction. Now coming to delayed hemolytic reaction. This is also hemolytic reaction, but it is a delayed hemolytic reaction. Why this delayed hemolytic reaction is occurring? It is due to antibodies that are going to recognize what? Red cell antigens. That the recipient was sensitized to previously. For example, I will explain this, just wait a moment. Just copy it down first. Through a prior blood transfusion. Now, this is our patient, and previously I have transfused blood from another person to this patient. At that time, what has happened was antibodies are formed. Now this time again I am transfusing the blood from the same person whom I have used his blood previously also. Now what happens? Antibodies are already formed. These antibodies are the ones which are attacking the red blood cells. That is why there is delayed hemolytic reaction. Okay. Please remember, this is delayed. Delayed is always due to IgG. Okay. Next complication is TRALI. What is TRALI? Transfusion related acute lung injury. Acute lung injury. This is your TRALI. Transfusion related acute lung injury. Why there is lung injury? The two, when you are transfusing blood, why there should be a lung injury? Why? Because of activation of neutrophils. Sir, activation of neutrophils, you are telling neutrophils are present throughout the body, but you are telling me acute lung injury. I accept there is activation of neutrophils, but where? In the lung vasculature. In the lung vasculature, there is activation of neutrophils. That is why there is acute lung injury. Now, this is somewhat a severe condition. This is somewhat a frequently fatal complication also. Once again. If the patient has already a pre-existing lung problem is there, pre-existing lung disease is already there, then the patient has more risk. Okay, then the patient has more risk to develop TRALI, transfusion related acute lung injury. This is due to antibodies that are going to bind to what? Major histocompatibility complex. I think I have discussed with you in febrile non-hemolytic reactions that they are mostly seen in RBC or platelets. But this condition, transfusion related acute lung injury, is more likely with fresh frozen plasma, or it is more likely with the platelets. So I am telling you transfusion related acute lung injury. Acute lung injury means what are all the features? Sudden onset, respiratory failure, okay, during or soon after a transfusion, okay, during a transfusion or soon after a transfusion. If the patient presents with sudden onset respiratory failure, then you have to think in terms of TRALI. Sir, you are telling me what? Acute lung injury. Then what I have to see on chest imaging? Can anybody tell me? I should be able to see bilateral pulmonary infiltrates. I should be able to see bilateral pulmonary infiltrates. I should be able to see. Okay. Now, sir, what are the clinical features? I have already told you fever is present in most of the cases. Not only that, here the patient is going to have hypotension. Not only that, and again he is going to have, what is the problem with lungs? When there is a problem with lungs, what happens? Can the oxygen diffuse? No, there is a problem with the diffusion of the gases. Now, what is the patient having? Hypoxemia. The patient is going to have hypoxemia. Okay. Now, there is nothing much we can do. We have to do only supportive treatment for this patient. Okay. Next complication. Infectious complication. Not that much important, but one such complication. So, what are the infectious complications? Infection means it may be, the blood product may be infected with bacteria, it may be infected with virus. Okay. Can anybody tell me what is the bacteria which might get infected? It is due to skin flora. Suppose I am the one who is donating the blood. While donating the blood, within my skin flora itself, there is some bacteria, and this is the most common. Which bacteria will cause this infectious complication? Means it is the donor, from the donor site where we are going to take the blood. Okay, occur at the time the product was taken from the donor, at that time this complication is usually occurring. Okay, now I want you to remember that this complication is much more common in platelet preparations than with red cell preparations. Can anybody guess why? Can anybody guess why this complication, infectious complication, is more with platelets rather than with the red cell preparations? Why? Because what is the temperature storage for platelets? They are stored at 22 to 24 degrees, means they are almost stored at a room temperature. You already know room temperature is something which is favorable for the growth of organisms. That is the reason why infectious complications are more common with what? Platelets rather than with red cells. Now, what are the clinical features of infectious complications? I have already told you, same routine. Fever will be there, chills will be there, sometimes hypotension may be there. These are the features. So, how to treat? You already know how to treat. We have to start broad spectrum antibiotics. For infectious complications, what I will do, I have to start antibiotics. Just we will go through all these things once. Why? Because this is very important topic. That's why I want to revise all these things. Okay. Okay, now this you can study. Nothing much to discuss about this. We will start with the complications. So the first complication I have mentioned is febrile non-hemolytic reaction. So I have already told you, anywhere there may be fever, there may be chills, there may be some mild dyspnea, and now this is the most common complication of a blood transfusion. It is going to occur within 6 hours. So why this why this reaction is going to occur? Because of inflammatory mediators which are released from where? From the donor leukocytes. Okay. Now, frequency of the increased storage. Okay. How to treat febrile? You have to give antipyretics. Now coming to allergic reactions, the patient has IgA deficiency. Now we have infused a blood which has IgA. The antibodies, the IgG antibodies which are present in the patient are going to attack the IgA which are from the infused blood, and now this reaction is occurring, that is allergic reaction. How to treat this case? Antihistamines. Now coming to hemolytic, two types, acute and delayed. Coming to acute, I am using the word acute. Why? It is due to preformed antibodies which are going to destroy what? Donor red blood cells. Okay. Now if I have done a ABO incompatible blood transfusion, then there is risk of acute hemolytic transfusion reaction. Now clinical features, fever, chills and flank pain, but most important point is they are going to appear rapidly. Now direct Coombs test positive, signs and symptoms are due to what? Complement fixation. Now I am telling you acute hemolytic reaction, there will be hemoglobinuria. Now severe cases, disseminated intravascular coagulation may occur, shock may occur, and acute renal failure may occur, and the patient even may die also. Delayed hemolytic reaction on the other side, previously the patient has got blood transfusion from the same person and now also he is getting the same. Already the preformed antibodies are there which are attacking the donor red cells. This is why reaction is occurring, that is delayed hemolytic reaction. Delayed you already know, which is always due to IgG. Now coming to transfusion related acute lung injury. So why there is a lung injury when you are giving transfusion? Because of activation of neutrophils, but where? Within the lung microvasculature. So this is a severe condition. This is a much frequently fatal condition. You already know that. Antibodies that bind to MHC, you have to remember, more likely with fresh frozen plasma. But whereas if you remember, I have already told you in febrile non-hemolytic, it is due to RBCs. Okay. But whereas FFP bar platelets are involved in where? In case of transfusion related acute lung injury. Acute lung injury means what? Sudden onset respiratory failure will occur during a transfusion or immediately following a transfusion. So what you can see on the chest imaging? Bilateral pulmonary infiltrates you can see. And how to treat means supportive features you already know, fever, hypotension. Lung injury is there, you can hypoxemia. Now coming to the infectious complications, infection may be due to bacteria, may be due to virus. Mostly it is due to bacteria. Which bacteria? Means skin flora. At the time when it is occurs at the time when we are taking the blood from the donor. Okay. Now with platelets or with red cells? It is more with platelets. Why? Because they are stored at room temperature 22 to 24 degrees. That is why infectious complications are more with platelets. How to treat? If you ask me, antibiotics I have to start.